Hello viewers, welcome back to my channel. In today's video, we will explore how oncology endpoints are derived in ADaM efficacy datasets. Endpoints like progression-free survival and overall survival are crucial in assessing how well a cancer treatment works. By the end of this video, you will have a clear understanding of the key concepts, data sources, derivation logic, and best practices you can apply immediately in your programming work. So let's get started. Let's first understand the major oncology endpoints. The first one is the progression-free survival, also known as the PFS. Normal definition for this will be the time from randomization to first documented disease progression or death. However, PFS measures the length of time during and after treatment that a patient lives with a disease like cancer without the disease getting worse or, in other words, progress. In clinical trials, PFS is often used to evaluate how effective a treatment is at delaying the growth or spread of the disease. Imagine a clinical trial testing a new cancer drug. Researchers enroll patients who all have the same type of cancer. At the start of the trial, they measure the size of the tumors in all patients. After a certain period, say 6 months, they check the patient again to see if the tumor has grown or not. If a patient's tumor has not grown, their progression-free survival is 6 months or more. If the tumor grew during the trial, that patient's PFS end at the point of tumor progression, and they are no longer counted as progression-free. So progression-free survival essentially tells us how long the drug keeps the disease from getting worse without necessarily curing it. If a drug exceeds or extends PFS, it may be seen as effective in controlling the disease. The next is the overall survival. Normal definition of overall survival can be given as the time from randomization to death from any cause. Overall survival measures the length of time from the start of treatment or diagnosis that a patient lives regardless of the disease progression. In clinical trials, OS is the most direct measure of the effectiveness of a treatment because it tracks whether patients survive longer as a result of the treatment. It counts the time from treatment or diagnosis until the patient dies, whether due to the disease being studied or another cause. Imagine a clinical trial testing a new treatment for a type of cancer. The researchers track all patients the researchers track how long patients survive after they begin the treatment. If a patient survives for 2 years after starting the treatment, their overall survival is 2 years, regardless of whether their cancer gets worse during that time or not. If another patient only survived for 1 year, their OS or the overall survival is 1 year. OS is the more straightforward measure because it simply counts the total time a patient lives, regardless of whether the disease has progressed. If a treatment significantly extends the OS, it suggests that the treatment helps patients live longer. The next is the objective response rate, also known as the ORR. And the normal definition of this will be the proportion of patients with a complete response or the partial response. The objective overall response rate measures the percentage of patients in a clinical trial whose tumor shrank or disappear after receiving a treatment. It specifically tracks patients who have a partial response, which is known as the PR, or the complete response, that is the CR. CR is the case where the tumor disappears entirely, whereas the partial response is the case where the tumor shrink by a certain percentage, typically at least 30%. ORR, which is the objective response rate, is a key indicator of how well a treatment is working to reduce the size of a tumor. Imagine a clinical trial where 100 subjects are being treated with a new drug. Researchers measure the size of each patient's tumor before and after the treatment. After the treatment, if 20 patients have a complete response, meaning their tumor disappear entirely, and 30 patients have a partial response, which means that their tumor shrank by at least 30%, 50 patients have no significant change in their tumor or their tumor grow, so they don't qualify for PR or CR. In this scenario, if we want to calculate the objective response rate, what we have to do is we have to add the number of patients with CR and PR. That will be 20 patients of CR, 30 patients of PR, in total of 50. Then divide the total number of patients with CR and PR by the total number of patients, which is 100. So in this case, the ORR will be the 50%. So what we understand is that 50% of patient has had a measurable reduction in their tumor after treatment. ORR gives an idea of how effective the treatment is at causing tumor shrinkage. The next is the duration of response, also known as DOR. It basically tells us how long the tumor remains in response after receiving or after achieving CR or PR. Duration of response measures the length of time that a patient's tumor remained shrinked or fully disappeared after showing a partial response or a complete response due to a treatment before it starts growing again. In other words, DOR tracks how long the patient's response, that is whether the tumor has shrink or has disappeared at one point of time, and after that it has again started to grow. In that case, the DOR tracks how long the patient's response to tumor shrinkage or disappearance lasts after it has been first observed. Imagine a clinical trial where 100 cancer patients are treated with a new drug. After treatment, 30 patients experience a partial response, that is, their tumor shrank by at least 30%, or a complete response, that is, their tumor disappeared. Let's focus on one of these 30 patients who had a complete response. After treatment, their tumor disappeared completely. The patient remained tumor-free for 6 months before the tumor starts to grow again. In this case, the duration of response for this patient is 6 months. DOR helps to understand how long a treatment keeps a patient's disease under control. Once the tumor has shrunk or disappeared, it is important to know how longer it takes to the tumor to reappear. So it is important. It is an important factor because a longer DOR suggests that the treatment might provide lasting benefits even if it doesn't cure the disease. The next endpoint is the time to progression, which is also can be defined as the time from randomization to documented tumor progression, but does not include death. The time to progression measures the amount of time from the start of treatment until the disease, such as cancer, begins to worsen or progress, that is, the tumor grows or spreads. The time to progression is used in clinical trials to assess how long a treatment helps delay the progression of the disease, providing insight into the drug's effectiveness in preventing the disease from getting worse. Imagine a clinical trial testing a new drug for cancer. Researchers enroll 50 patients and track the size of their tumors at the end of treatment. Patient A, after 4 months of treatment, the tumor starts growing again. So the TTP for patient A is 4 months. For patient B, after 6 months of treatment, their tumor starts growing. So the TTP for patient B is 6 months. The time to progression is the time from the start of treatment until the tumor begins to grow or the disease worsen. It gives an idea of how long the treatment can keep the disease from advancing. If a treatment has a longer TTP, it means it is helping patient remain disease free for a longer period. These endpoints are fundamental in determining how effective a cancer treatment is over time. Now let's talk about the source data for these derivations. Primarily, these are the SGTM domains such as the RS domain, which is the response evaluation domain, which captures the tumor assessments like the CR, PR, SD, or PD. Another thing is the disposition domain, which can provide the information on death events. The third one is the adverse event, sometimes used for death confirmation. And next is the LB, which can be occasionally used for tumor markers. Having complete and accurate and clean SDTM data is critical before starting any derivation work. Now let's talk about the key variables in ADaM efficacy datasets. In ADaM dataset, we use datasets like the ADTT, which stands for time to event datasets. In this dataset, the param CD or the parameter code is one of the more topic variable of the ADTT, you can say, and this variable is used to specify the time of event the type of event being measured in the dataset. For example, the progression-free survival or overall survival can be represented here. For an example, again, the param CD if is equals to PFS indicates that the dataset is focused on the time to progression event. Next is the AVAL, which is the analysis value. This variable stores the actual value of the time to event for each individual subject. For instance, if the time from start of treatment to disease progression for a subject is 6 months, AVAL will contain a value of 6. The next is the CNSR, which is the sensor indicator. This variable indicates whether the subject data is censored or not. That is, the event has not occurred by the time of analysis or the subject has dropped out of the trial. A typical value of 0 typically means the event was observed, while 1 indicates that the data is censored. That is, the subject did not experience the event before the analysis. For example, if the CNSR is 1 means the data is censored and the subject did not experience the event, which is progression during the study. One might ask that why is censoring important? Censoring allows the inclusion of subjects who may not have experienced the event yet, but whose data can still provide useful information about the overall trend or the effectiveness of the treatment being tested. By accounting for censored data, clinical trial can provide more accurate and reliable estimates of outcomes such as the progression-free survival or the overall overall survival. To understand this concept, let's take an example that where in a clinical trial, let's say there are 100 patients being treated for cancer and we are analyzing the progression-free survival. In this case, a patient A has progressed after 6 months, so their CNSR will be 0 and their AVAL is 6 months. For patient B, who has not progressed by the end of the study period, that is 12 months, so they are censored. Their CNSR will be 1 and the AVAL is 12 months since they survived without the progression for 12 months. Similarly, if we talk about another patient, say patient C, who drops out of the study after 8 months before any progression, so they are censored in, so their CNSR will be 1 and their AVAL is 8 months. Even though patient B and C did not experience progression, their data still help assess the treatment's effectiveness, indicating that they stayed progression free for a certain period. Another key variable is the ADT, that is the analysis date. This variable contains the date of the event or censoring, used to calculate the time to event. For example, if a patient's tumor progression date is 1st June 2025, then ADT will reflect this date as the day the event occurred. Correct population flags like the safety flag or the efficacy flag must also be carefully handled to ensure correct inclusion. Now let's walk through how some of the common endpoints are derived. Let's start with the progression-free survival. As we have discussed that the progression-free survival is used to calculate time from randomization to the earliest of the disease progression date or death date. If neither occurs, the censor at tumor assessment date is being considered. Now, if we talk about how to calculate this progression-free survival data, that is the derivation, how we have to proceed. The step one is that we have to start with the start date of PFS, that can be the first dose of treatment. For patient receiving combination therapy, the start date is based on the first dose of the treatment regimen. The second one is to understand what the progression-free survival refers to. So in this case, we should understand what is the progression and what is the death means. So if let's see there is a progression event, then what does that mean? That means that the disease has progressed or the tumor has grown and spread, and it is defined again. Whether the tumor has spread or grown is can be defined using the RACIST guideline. And if if an event is happening which is considered as a progression of the disease, then that is also one of the case of the PFS event. The another event is the death. If the patient dies before progression occurs, death is also considered as the event, and the PFS ends at the date of death. The third thing which we should be knowing is that what is censoring in this case. The censored data for a subject who is still alive and has not progressed by the end of the study period, or if they are lost to follow up, their data are censored. The censor indicator, which is CNSR, is set to 1, and the patient's time to event is calculated up to the last date the patient was known to be progression free. An example here is one which we have discussed earlier also, that a patient is progression free for 12 months but drop out of the study at that point. In that case, the PFS for that patient is considered as 12 month and they are censored at 12 month. The end point is how to calculate the PFS time calculation. The PFS time is the number of months or days from the start of treatment until either progression or death happens. If progression or death occurs, the PFS time is calculated from the first dose dates to the event date, which is the event of progression or death. In case both the progression and death has happened, then make sure that you consider the earlier event date. That means that if death has occurred after the progression, then we have to consider the progression date as the PF in the calculation of the PFS time. If censor occurs, that is that the subject did not experience progression or death, then we will be considering the PFS time as the first dose date to the last date the patient was known to be progression free. Let's understand this progression free derivation with an example. Here I am showing you the data for 4 subjects. The patient 1 experienced the progression and the PFS time was from progression the start date, which is the first dose, which is on 1st January 2024, and the progression date is on 1st May 2024. This subject did not experience death, so And since it experienced the progression, the censoring indicator variable is marked as 0 and the event is progression. Similarly, for the second subject who experiences death on 1st of July 2024, and for that subject the start date was 15th of January. Again, since this subject experiences death, the censor variable is marked as 0 and the event is death. For this third subject, this subject did not experience progression or death, but so this was marked as the censor variable, and the last known date for this subject was the 1st of August 2024. Same is the case with the fourth subject who did not experience death and progression, and the last known date was the 1st of June 2024. So for both these last two subjects, the censor variable is marked as 1. Now let's talk about the overall survival. The overall survival is calculated the time from randomization to death. And death can be from any cause. If the subject is alive, censor at the last known date is considered. For OS endpoint, as we have talked about that the time from a specific starting point, that is randomization or treatment initiation, to the event of death or until the subject is last known to be alive is considered. Let's study here the step-by-step derivation for calculating the overall survival. The OS endpoints is generally derived from clinical data source that includes the date of randomization or the first years of the study drug. The second is the date of death if the subject is deceased, and the censoring information, that is whether the subject is still alive or lost to follow-up. If the subject is alive, then we should know the last known alive date also to mark the subject as the censored subject. So first we have to identify the starting point. The starting point will be the date of randomization or the date of first dose or the date of consent based on this study. For simplicity, we will assume the date of randomization as the choosing starting point. The next step is the event date. That is to identify the event date, and in this case, in overall survival, the event date is the date of death. If the subject is dead, the date of death is used. However, if the subject is alive, the event is censored and the subject is not considered as having the event. For censored subject, we use the last known alive date. Now comes the next step, that is the calculating the survival time. The OS time for disease subjects will be the date of death minus the date of randomization or the first dose, whereas for the censored subject, the OS time will be the last known alive date minus the date of randomization or the first dose. However, if the date of death or last known alive date is missing or unavailable, the OS time may be flagged as missing. If the randomization or the first dose days is missing, the OS calculation should be flagged as missing for that subject in that scenario as well. Let's understand the overall survival derivation with an example. In this table, the first subject is the subject who has died. The start date for this subject, or the randomization date you can say, is the 10th of January 2025, and the event date, which is the date of death, is 15th May 2025. So the OS time will be calculated as date of death minus the start date, which will come out as 125 days. Similarly, For the second subject who is alive at the end of the study and is censored, the start date for the randomization is the 1st of February 2025 and last known alive date is 1st of August 2025. The OS time will be derived as the last known alive date minus the start date, which comes out to be 181. The third scenario is a scenario where the subject has missing dates. We have the randomization date, that is the 5th of March 2025, but we do not have the date of death or the last known alive date. So in this case, the OS time is marked as missing. And since we do not know if the subject experiences the death or was still alive at the time of this assessment, we cannot mark the censoring flag or the censor indicator variable as well. So for that scenario, the censoring flag is also kept as missing. The next is the overall response rate endpoint, and let's see what's the derivation logic for this. As already discussed earlier, the ORR is, which is the objective response rate, is calculated as the number of subjects with either a complete response or a partial response divided by the total number of evaluable subjects. So if we talk on the mathematical formula wise, what we have to do is, as a numerator, we have to take the sum of subjects who experiences the CR or PR, and in denominator we will have the total number of evaluable subjects, and we will calculate the percentage of it by multiplying by 100. So in this way you can get the objective response rate. Let's understand the objective response rate with an example. In this case, you can see the best overall response, which is BOR, having values such as CR, PR, SD, PD. To calculate the objective response rate, we should consider the records. We should consider the records which are having CR and PR. So in this example, you can see that the subject 101, 102 is experiencing CR and PR, as well as the subject 105 and 106 is also experiencing PR and CR. So in total, if you see from out of these 6 subjects, so if you notice, these 6 subjects will be there considered as the total evaluable subjects, which will be the count which we will use for the denominator. And if we want to count the number of subjects with CR or PR, which is our numerator, it will be 4. 2 subjects for CR, 2 subjects for PR. So the ORR will be 4 divided by 6 multiplied by 100, which will come out to be 66.67%. So by this value, which is 66.67%, what does this mean? This means that 66.67% of the evaluable subject experiences either a complete or a partial response to the treatment. Now let's talk about the duration of response and endpoint derivation logic. The duration of response is the time interval from the first occurrence of a complete response or partial response to the first occurrence of progressive disease or death. The DOR is calculated for responders only. Now, what are responders? Responders are the ones who have achieved CR or PR. It is not calculated for subjects who have stable disease, that is SD, or the progressive disease, which is PD. So if we talk about the key variables in DOR derivation, those are the complete response, the partial response, the progression disease, or the time to progression. For partial response, we have already discussed it multiple times that it is that at least a 30% decrease in the sum of the longest diameter of the target lesions, and the complete response is the complete disappearance of all the target lesions, whereas the progression disease or the progressive disease is at least a 20% increase in the sum of the longest diameters of the target lesion or the appearance of new lesions. These definitions are coming from RACES guidelines, so make sure if you are following these definitions, then you are using the RACES guideline in your study. The time to progression is the time from the initial response until disease progression happens. And another key variable is the death. So, the next step is in deriving the DOR is to identify the subject who has responded. That is, who has CR or PR. So we will consider the best overall response and we will determine if they have a complete response or a partial response. Only those subjects with a CR or PR are considered as for DOR calculation. The next is to define the start date of DOR. The start of DOR is the date on which the patient first achieves either complete response or partial response. This is typically derived from the RS domain in SDTM or the relevant response assessment data. The next step is to define the end date of DOR. The end date of DOR is the date on which either disease progression is first observed or death occurs. If a patient dies without having disease progression, death is used as the event to define the end of DOR. Now comes the time of calculating duration of response. Duration of response is the difference between the start date, that is the date of first PR or CR, and the end date, that is the date of progression or death. If a patient has not experienced progression or death by the end of study, their DOR is censored at the last known follow-up date, that is the date of last response assessment. Now comes the censoring rule for DOR. If the patient is still alive and progression has not occurred by the end of the study, the DOR is censored at the last response assessment date. If the patient had a response but was lost to follow-up or withdrawn from the study, their DOR will be also censored at the last known assessment date. Let's understand DOR response derivation with an example. In this table, for subject 101, the first response date, that is the partial response, was the 10th of January 2025. And the progression date was 15th of May 2025. The DOR calculation will be from 10th of January 2025 to 15th of May 2025, which is 126 days. This is not censored as the progression date is known. For subject 2, the first response date is the 1st February 2025, which is the CR, and the progression date is 10th of April 2025, whereas the death date is 20th of April 2025. So for DOR calculation, we will consider the first response date, that is the 1st February 2025, and the progression date, that is the 10th of April 2025, which is 68 days. Subject 102 has progression on 10th of April 2025, so the duration is calculated based on this date and not based on the death, because progression happened before death. So coming on to the subject third, the first response was the partial response, which happened on 1st of March 2025, and the progression also happened on the 6th of June 2025. So the DOR calculation will be the difference of these 2 days, which is 101 days. This is censored because the subject has not yet reached progression at the study end date. The subject 104 did not achieve a response, so DOR is not applicable. The first response date for subject 105 is the partial response date, which is 15th of January 2025. The progression was not observed, so the DOR calculation is censored at the last known follow-up date as there has been no progression or death. The exact censor date depend on the last follow-up or the study closure date. So final DOR table comes for these 5 subjects are as follows. Since for 104 subject the DOR was not applicable, so we do not have that subject in the final table for DOR calculation. Let's talk about the consideration and the practical points while calculating the DOR here. The first is the censoring. If the subject had not any disease progression or death by the end of the study, their DOR is censored at the last valid assessment date. Next is the event of interest. The end of DOR is defined by either progression or death. If the patient dies but has not shown progression, death is considered as the event for calculating DOR. Typically, Kaplan-Meier methods or other survival analysis techniques are used to estimate the median or mean duration of response across all patients with a response. The DOR mirror how long patients who respond to treatment continue to benefit from that treatment before progression or death occurs. It is the first from it is the time from the first PR or CR until disease progression or death with censored data if progression or death does not occur during the study. The next endpoint is the time to progression endpoint. So now let's talk about its derivation logic. The time to progression is a crucial endpoint in oncology clinical trial used to measure the time from randomization or the start of treatment until the disease progresses. The disease progression typically refers to an increase in tumor size or the appearance of new lesions based on radiological assessment, but it can also include clinical progression. As we have discussed, the time to progression is the time from start of treatment or randomization to the first occurrence of disease progression. Disease progression, we have discussed that it is the 20%, at least 20% increase in the sum of the longest diameter of target disease lesions or the appearance of new lesions or the worsening of symptoms indicating disease progression. The TTP, that is the time to progression, is calculated for all patients who have not already experienced progression at the start of the treatment. The key variables in TTP derivations are the progression disease, that is PD, the stable disease, and complete response, partial response, and the date of progression. Now comes the steps to derive time to progression. So the first step is to identify the patient who have not progressed at the treatment start. The TTP is calculated only for patients who have not experienced progression by the time they begin treatment or are randomized into the study. So we have to exclude the patients who have PD at the start or those who drop out from the last who drop out from before the first progression event. The step 2 is to define the start date of TTP. The date for TTP is typically the date of randomization or the date of first dose of treatment. The next step is to define the end date of TTP. The, the end date for TTP is defined by the first occurrence of disease progression, which is the PD. Note, if the patient dies before progression is recorded, the time to progression is considered censored at the time of death. If the patient is lost to follow-up before progression, that event is also censored. So now comes the censoring rule for TTP. If a patient has not yet shown progression or died by the end of the study or last known follow-up, their TTP is censored at that last known time point, which is also known as the right censoring. In rare cases, a patient may have experienced progression before the start of the trial, in which case the data is left censored. If progression occurs between two scheduled visits, it may be considered interval censored, and an estimate for TTP may be based on the available data. So the last steps comes to be how to calculate the time to progression. The TTP is calculated as the difference between the start date, that is the first day's dose or the randomization, and the date of progression, in case the progression happens. And in case of censoring, it will be the difference between the censoring date and a randomization or the first dose date plus one. Now let's talk about the time to progression derivation with an example. In this table, you can see that for the first subject, the start date is the first dose date, which is on 10th of January 2025, and the PD date is of 20th of May 2025. The TTP calculation can be done by subtracting these two dates, which comes out to be 130 days. Same is the case for the next subject, and we can calculate the TTP days by the subtraction of the PD date and the first dose date for this subject, that is subject 102. For the subject 103, there was no progression, as well as for subject 104, there was no progression. So for these two subjects, the TTP is censored at the last known follow-up date, or that is the last known date where the subject was still in remission at study conclusion. For the last subject, which is the 105 subject, same is the case that this subject experiences the progression. So we will have the difference between the progression date and the first dose date to calculate the TTP, which comes out to be 106 days. This is the final data set for the time to progression based on the shown earlier shown data, that you can see that for 101, 102, and 105 subjects, we have the TTP days mentioned and the censoring flag and note as progression at 130 days and so on. Similarly, for subject 103 and 104, since these two subjects did not experience any PD, they were considered as censored. So in notes, we have mentioned that no progression and the subject was censored. Now let's see a sample table example. In this table, the first is the use subject ID column, next is the randomization date column, then is the progression date, death date, last tumor assessment date, the best overall response, and the last is the new enter cancer therapy start date. In this sample table example, you can see we have data for 5 subjects. Out of these 5 subjects, 2 subject experiences the progression, one experience has died, and one underwent the new enter cancer therapy. For out of these 5 subjects, SD happened for 2 subjects, whereas PR, CR, and PD happens for 1 subject respectively. Now let's see the SAS code which we can write to derive the PFS, that is the progression-free survival, as well as the overall survival based on this sample table. I am going to consider this sample table as the source data set in the SAS code. So first is the PFS, that is the progression-free survival SAS code example. Again, this is an example based on the example data which I have taken. So in your own study, there might be some extra or a different conditions. So make sure you identify those conditions and program accordingly. Right now, I am giving you just a glimpse of how the SAS coding for the PFS derivation looks like. So I'm reading the source dataset to create the ADTT dataset. So the first step is to derive the sensor or the event date. In PFS, that is the progression-free survival, the progression or death is considered as the event, whereas if the subject experiences neither of these two, then that subject is considered as the censored subject. So what we are doing is that we are checking if progression date is not equal to null, then the event date will be the progression date, and if date is not equal to null, then the event date will be the death date. The last scenario is whether when the subject did not experiences either of these two. In that scenario, the event date will be the last tumor assessment date, or in other words, the last disease evaluation date. So the next is to derive the censoring flag, which is the CNSR variable. So if the subject has experiences the progression or death, then the progression date or death date, either of these two will be not null. So what we are doing is we are checking using the if else condition that if progression date is not equal to null or the death date is not equal to null, then the censor variable will be 0, which is that the event happened. Or else, if this is not the case, then the censor variable will be 1, which means the subject was censored. The next step is to derive the PFS time in days. So it is captured in the AVAL variable. So the derivation for AVAL in this scenario will be the event date minus the randomization date plus 1. Please note that right now when we are considering the event date for the censored subjects also. Why? Because while deriving the event date, we have taken into consideration that when the subject is censored, we are populating the event date with the last tumor assessment date. So this derivation of AVAL stands true. The last step for the PFS derivation will be the population of param CD and param as PFS or the progression-free survival. So using this SAS code, you can create the PFS param CD records in ADT TTE dataset using the source dataset which we have just seen. Next is the derivation of overall survival data using the SAS code. Again, we are reading the source dataset and creating the ADTT dataset. So the difference between the OS and PFS is that in case of OS, we are mainly concerned whether the subject experiences death or not. So if the subject has died, that is, if death date is not equal to missing, then the event date will be the death date, and since that means the event has happened, then the censor variable, which is CNSR, will be equals to 0. Else, if the subject has died in that scenario, if the subject has not died in that scenario, the subject will be censored, which means the censor variable will be 1, and we are populating the event date as the last tumor assessment date or the last available assessment date here. So again, the AVAL, param CD, and param derivation remains the same, which is the event date minus the randomization date plus 1 as the AVAL, and param CD for overall survival will be OS and param will be overall survival. Running this code will ensure that you create the overall survival param CDs for the source dataset. Another point to note here is that for better clarity between the PFS and OS. In these examples, I have added a suffix of underscore OS to these variables. But in reality, when you will be creating the ADTT dataset for these two param CD, you will be using the same variable, which will be the event date or the CNSR, AVAL, param CD or param variables, and you will not suffix anything. To summarize, oncology endpoint derivations involve careful handling of dates, censoring rules, and logical programming decisions. A strong grasp of both the clinical and data programming aspects will help you develop clean, validated dataset ready for regulatory submission. If you find this video helpful, don't forget to like, subscribe, and comment below if you want me to dive deeper into topics like deriving PFS from scratch using sample data. That's all for today. Thanks for watching. Let me know in comments if you want me to cover any specific topic.